Good evening, everyone. My name is Dr. Stuart Frost from sunny Arizona. It's a pleasure to have you aboard tonight. Yes, I live in Arizona and it is hot. We're enjoying our beautiful hot summers, and if you've ever been here, you'll know what I'm referring to. It's a pleasure to be with you. I'm going to spend some time tonight talking about how do we accelerate our practice with manual osteoperforations and high-frequency vibration. My email is frostortho@gmail.com. My Instagram is at Dr. Stuart Frost. If you ever have a question afterwards or you want to reach me, you're welcome to on these two outlets. Let me give you a little bit of what's going to happen tonight. I'm going to have about an hour presentation where we'll talk about this topic, and about 10 minutes before the end of it, we'll have a question and answer. You're welcome to type in questions whereby at the end we'll answer questions the best we can, and it's a pleasure to be with you. I'd like to get started now. You know, it's important for me to give a little disclaimer. I'm not employed by any dental company. I have my own private practice here in Mesa, Arizona. I've been in practice for 17 years as an orthodontist. For the past 10 years, I've lectured around the world on orthodontics, accelerating your practice, and the Damon system. I do not have stock in Ormco, although I do have stock in OrthoFi and Oral 4D. I do not have any family members employed by any of these companies, and I've consulted or been a KOL for Propel, Orthodontics, Ormco, Excellident, iCat, Wave, and Oral 4D. So with that, let's get started. Well, what we're going to do tonight is talk about osteoperforation and how to increase the predictability and accelerate orthodontic treatment, really with a focus on micro-osteo or manual osteoperforations and high-frequency volume or vibration with aligners, brackets, and wires. And we're going to get down to basics and talk about how we can use this in our practice. And you might ask yourself the question, why is this important to you, or why is this important to myself? And I got to tell you, this is an important time in our profession because we are constantly having changing and we're embracing new technologies, and it's all to enhance our patient's experience. These new technologies are benefiting our patient, increasing our efficiency and shortening our treatment time. So if you want to be on board with that, that's what this lecture is going to be about. And by the end of this webinar, I will have shown you a simple way to start growing your practice with accelerated treatments such as manual osteoperforations and high-frequency vibration. What is the future of orthodontics? Well, if we all had a crystal ball, we could know we might be able to save ourselves time and hassle, but there really isn't such. But I believe that accelerated treatment and innovations really is where our future of orthodontics is, and we've got the best technology we've ever had in our profession, but if we want our practices to continue to grow and survive through these changing times, we must change with them and not be fearing change, but embrace it. We must be more efficient with our treatments and have the best outcomes possible. So how do we do this? Well, we're going to talk about that tonight. I want to just make mention of somebody that I feel has been a leader, a thought leader in dentistry through the years. This is Dr. Degoni. He was the dean of my dental school, and at one of his graduation addresses, he mentioned some interesting things on fearing change and technology and change in our profession. And he said the thoughts on orthodontics 65 years ago were this. He felt like that, and dentistry, that high-speed handpieces would destroy nerves, and we know that that really didn't happen in their routine at every dental chair. He said implants, they thought back 65 years ago that implants would cause bone infections. Well, they're 99% successful today. Fluoride would cause cancer. We know that decreases caries dramatically. And orthodontic surgery, it was thought that you might lose the maxilla or have a loss of a jaw. We know we have great successes with two-jaw surgery. It's interesting because I've always looked at Dr. Degoni as a thought leader in dentistry, and I teach at the University of Pacific in the orthodontic department. And it wasn't but 2 years ago, Dr. Degoni was having a birthday, and he was 90, I think, at the time. And I looked over at his birthday there, and here he was, and I'm looking closely, and I see him on his iPhone. And I thought, wow, here is a thought leader in dentistry, and he's on his iPhone. I'm sure he was texting a grandchild or a great-grandchild, and truly embracing change. That's what we have to do if we want ourselves as a profession, our professional and our practices. If we want to survive these times, we have to differentiate our practices. And how do we do that? We do that through innovation and technology. And I'm here to talk to you about some innovations and technology that will help grow your practice. Before we get too much into this, I want to talk slightly about the science behind manual osteoperforation. And we'll keep this very basic. But basically what this is we are creating with manual osteoperforation a bone injury or an inflammation. And we know that when we create an inflammation, we have cytokines that flood to the area, and cytokines increase, and that triggers this bone remodeling and the rate of bone remodeling. And obviously that goes up and the bone density goes down. Thus we've started this process of moving teeth and moving teeth a little faster. How does it really work? Well, there's been articles that have been written, it's listed below. In orthodontics, we know that the rate that bone remodels really determines the speed of tooth movement in a patient's treatment time. And I think that for me, even 25 years ago, when I entered dentistry as a general dentist, watching some orthodontists create new brackets that supposedly caused cases to move faster, that really caused root resorption, and that was my concern when I first started doing manual osteoperforation. And so we have seen some of these articles that are written, decades of research refined into a simple and easy in-office procedure using osteoperforations. Moving teeth faster is now easier without those complications of root shortening, and we know that it's clinically proven safe. So dense bone then becomes temporary softened, if you will, internally. This will be undetectable to the patient, but allows these movements to occur faster and easier, as you'll see here in a few minutes with some cases I show. When incorporating osteoperforations into a patient's orthodontic treatment, the tooth movement can be increased by 2.3-fold. We all have watched and learned in our biology classes how this works. We put a force on one side, we create on the pressure side, vascular constriction, decrease of cell proliferation, and you know the rest here. We get frontal resorption and the tooth moves. And the whole key that we all want in treatment is that full bodily movement with the force, putting enough force or tension on a tooth to move it bodily, and without getting a very avascular necrosis. So that's our key. Basically, when we increase the force too much, we get undermining resorption, and we have necrosis, and we have this tooth begins to tip instead of full bodily movement. And that's really the premise of what we're trying to do here, is to use osteoperforations to increase that tooth movement, so when we put just the right amount of force on them, we get bodily movement. Of course, you've seen this over and over again, and we're just trying to increase the amount of bone remodeling on a faster level and do it to where the tooth moves bodily and we have great progression through tooth movement. So I think that for me, this New York University clinical study is what has been powerful, and it was published in the AJODO. And here's some key points from this article, and I love what was written and studied here. Basically, the effects of osteoperforations on the rate of tooth movement. The study utilized a micro osteoperforation device to create the micro osteoperforations. That reduced treatment time by 62%. Clinical trials demonstrated 2.3-fold increase in the velocity of the tooth movement, specifically in canine retraction when using micro osteoperforation. Bodily movement was shown without tipping, and I think that's the key, which we were just describing, is how do we use these osteoperforations to help us have bodily movement instead of just tipping and then moving root, tipping, and so on. Patients reported little to no post-treatment discomfort. We're going to talk about how we handle that here in a few minutes with our our post-treatment. Moving on with this, this study is just showing what they did and sliding mechanics and moving a custom back. At the time of treatment, left side was treated with Manual Osteoperforations, right side is the control, and 24 hours post-treatment, soft tissue is completely healed. You can't tell where it was done, and you can see what's happening with the movement. Left side had significant more canine retraction than the right side, and that's from day 28. You can see on the occlusal view 28 days later and what's happening with the canine retraction. So there are different modalities in accelerated orthodontics today. I've tried many of them, and I'll touch briefly on what I have tried and comment briefly on what I've seen. I'm a clinician. I'm not a researcher. I look at things very closely in my practice. I take study models. I have photographs at each appointment so I can see what's going on and be able to identify areas that really do work. And I've been down this road with patient-controlled accelerated orthodontics. I've used low-frequency vibration, and it was indicated to facilitate minor anterior movements, aligners, helping teeth seat into aligners. These devices are rechargeable and requires the patient really to self-administer for 20 minutes a day. Now, in the beginning, 6-7 years ago when I started using this, the costs were very expensive, and those costs have come down. But this type of accelerated orthodontics really is patient dependent. They have to use the device for this to work. There's others now. We have high frequency vibration for accelerated orthodontics, and again, still patient controlled accelerated treatment. This high frequency vibration is indicated to help with good aligner seating, and aligners must remain in the mouth during treatments. Rechargeable device requires patient to self-administer. The great thing about high frequency vibration is this is only 5 minutes a day, and the cost is significantly less at around $400 per device. Again, though, relies on patient compliance. There's some other devices that are out there that I won't comment too much. I have 2 of these devices, light activated bone regeneration with a mouthpiece, requires patient to self-administer for about 20 minutes a day, and patients reported to me less pain with tooth movement. So I have tried some of these as well. So these are basically what we have in our patient-controlled accelerated orthodontics. Doctor-controlled accelerated orthodontics. Back in my residency in Rochester, New York, there were some Wilco brothers back in the East Coast who were doing some fantastic work with accelerated orthodontics and doing corticotomies and bone grafts. If you want teeth to move quickly, the Wilco brothers have shown fantastic research on this. This is probably the most invasive of the controlled accelerated orthodontics from the doctor. Time sensitive, requires patients to have a recovery time. There's a high cost from the surgery that is from a surgeon or a periodontist, and requires extensive training for a clinician. So corticotomy on the bone, micro perforations there with the high speed. Sometimes bone is placed in these areas as well, along with the corticotomy. And then we have piezo surgery, and piezo has come on where this is less invasive than a corticotomy. Still requires a vertical flap and or a tunnel procedure. Requires patient recovery time. It's high cost to the patient, again requiring a surgeon or a specialist to come in and lay the flap and do the piezo surgery. But great results with movement. And then the other is the manual osteoperforations, which we'll be talking mostly about today, which again is doctor-controlled acceleration, micro-invasive, and no patient recovery time needed. Virtually low to no cost to the patient, and there is a little bit of training for the clinician. We'll talk about that today, and really that's minimal training necessary. It's basically we numb the patient up, we do it in office, and it's very simple and straightforward. So those are the areas. There are others areas that are doctor controlled, and but for most part there's surgery first, and some laser therapy as well. But in my practice, this is what we've tried so far. Now, I've used the manual osteoperforation devices. This is one of the very first devices that I used. It's a driver that creates these perforations to stimulate that cellular response we talked about earlier, harnessing a patient's own biology to accelerate the tooth movement. This one is a single-use device that after it's done and you're done using it, you will toss it. And it has a depth limiter on it here, which you can see right in this area here. And the surgical steel construction, conveniently packaged for single use, has ergonomic design, and really is enhanced for tactile sensation and control. These are good because you have your depth indicators up here, and when you can set this to a certain depth, and when you get to that depth, this will blink red, telling you that you're at your depth. So this was a great way to get started if you're concerned about how far you go into the tissues and into the bone. We'll talk more about that here. But this sleeve is retractable, so as you're screwing the screw into the bone, the sleeve is retracting and then the light will light up. This is another osteoperforation device that I've used. Again, it's manual, and it will do the same thing. Stainless steel tip, and it's disposable. Now this is cool because you have disposable tips. You have this really smooth handle, which I've used quite a bit, and I really like the design of this. It has a large handle, texture grip for stability and control. The tip construction ensures that integrity for maximum manual osteoperforations. Again, if you're doing full mouth osteoperforations, you want to have a tip, a stainless steel tip that's not going to dull after one or two areas and using. So we've got a unique flute angle that minimizes that soft tissue impact. With these last two that I've talked about and having that plastic sheath up here, as you can see, there is some soft tissue impact from the plastic sheath that goes around. Again, we have depth indicators, and those depth indicators, there's no light on this one, but you can see there's the 3 and 5 and 7 millimeters. So that's a reusable handle. This is a electric osteoperforation driver that I actually now use in my practice. This is the only thing I use. Once you start using this manual driver that's electric, you really won't want to go to anything else, and this is fantastic. It harnesses our own body to accelerate the tooth movement, but it does it in a way without making your arm exhausted and tired as you're going along. So this device is on a contra angle, and it looks very similar to some of the other drivers that I've seen with TADs, and it will reach difficult areas with ease. It has 3 speeds, setting ranges for up to 45 RPMs. It's user-friendly, has a great LCD panel. You charge it up before use. It has push-button display. It has a reverse function, which is really, really nice. So as you turn this on and hold the device up to the gum tissue into the buccal bone, there's not a lot of force or pressure that has to be put on there, and it engages very nicely. Once you've got to your desired depth, you push the pause button here, or the start button. It pauses it. You can hit this button, which reverses it. Push the play button or the on button, and it'll reverse it back out. Very simple, very easy to use. Again, patented thread design creates these perforations with ease. And I got to tell you, the stainless steel tip stays sharp throughout all of, especially if you're doing full mouth manual osteoperforations. So a few other things, we can hit all the different areas. It is comfortable to use. It has optimal torque and speed and makes it fast and easy. Now, I know some people are using their TAD drivers to do this with a TAD. I don't recommend that. That would take a long time if we're using a TAD driver. But for me, this driver is very speedy, and it makes it very nice. Surgical stainless steel assures that tip strength and integrity. And again, I talked about a minute ago about that thread design allows you to do the whole mouth, upper and lower. So We can use this with cases using braces or clear plastic liners. Here's the components with the electric driver. You can see this nice one-time use surgical blade or stainless steel. It's sharp, it works well. It's in our latch here, and you open the latch, put this in, close it. There's no question that that's in place, and it works fantastic. So like I said, this is in what I use in my practice. I wouldn't go back. You couldn't pay me to go back. As far as the cost on this, I can't remember. I think it's over a couple $1,000s, but it sure it's worth it. Now we want to make sure it's fully charged. We leave in the smart charger. We secure that tip in the contra-angle head, and make sure it's fully seated. We press and hold the power button, and it'll turn it on. You can see the power button's right down here. We hold it, it turns on. People are asking me what RPMs. We recommend high, and then what torque value. I recommend starting out at a 15 Newton centimeters for our torques, and you can play around with that and decide what you want to do, but we do have the ability to go up to 45. Increase the settings as required to reach the desired perforation depth. There's two modes, a general mode, which again you press start and stop briefly to start the rotation, and you push that start stop button, which is again is right here, and that will stop it. The reverse button is great to back that driver out, and very easy. There's another mode called the temporary mode. You can press and hold the start button for at least 3 seconds. The driver will stop immediately when the button is released. So that's nice if you want. I like the control of the general mode. You can position the contra angle in different manners, meaning that, I'll go back for 1 second here. If you look at this collar, you can lift the collar and it will allow you to position this contra angle to whatever is comfortable for your grip so that you can hit the start and stop button easily. Tip is 90 degrees, which really helps for the contact and facilitate that quick engagement. So this is what we do. The reversing is awesome. We push forward, reverse, and it just saves you energy and time in doing these perforations. So with that, when you're done, you can throw the tip away. It's a single use. You get another one for the next patient. Let's talk about manual osteoperforations for patient benefits. Basically, this is minimally invasive, and we'll talk more about this in a few minutes when I show you cases. I haven't had any patient come back and say that was the worst experience of my life. People are like, yeah, no problem. Little tender, no big deal. The technique is performed chairside, and it does take time to do this, and when you're doing full mouth, it does take a little time. I like to do it when there's not a lot of people in the clinic, a lot of other patients, and it is done by the clinician. We can use these manual osteoperforations. I'll show cases here in a few minutes with aligners or with braces, and it really does release or turbocharge, however you want to call it, difficult movements. It accelerates treatment. I'm going to show you a case that should have been an 18-month case. I treated in about 12 months. We increase the treatment predictability, and there really isn't any patient recovery time needed. We don't have to pay large bills to another surgeon to help us. This is doctor controlled. We're not relying on the patient. It works fantastic. We'll save time. There's less office visits, means less time off work or school for the patients we're doing that on, or our adult patients. They don't have to miss work as much. Other practice benefits: provide cutting-edge technology. People always come in my practice and they say, what's new in orthodontics? What are we doing that's going to help me get done faster? And it provides me an opportunity to talk to them about this. You'd be surprised. In my practice, many of the adults are female, and they are between the ages of 40 and 60, and they're the ones that are saying, I want to do this. And of course, we all know that women are tougher than men, but it works out fantastic. Increased treatment acceptance. Patients are more likely to accept a faster treatment time. Attracts new patients. Patients today are looking for that faster treatment times, practices that are embracing the latest technology. And really, there is a little bit of a premium, and we do charge a little bit more for this, but it does reduce treatment time, which is awesome. And I think that really what it comes down to today, most patients are looking to be treated in under 12 months. And we need something that's going to help us get these patients before they burn out and get them out of treatment. I'd like to take a moment here and show you the step-by-step and give you an idea of how osteoperforations work. There's basically 3 easy steps in minutes. We want to evaluate the treatment area. And what I use in my practice is I have a cone beam, and I can come in and look very quickly at the roots, the bone, and make sure that all those areas that I'm going to be perforating have good space between the roots. So I will go in and look in 3 dimensions and really design where I'm going to perforate, unless it's a full mouth perforation, which you'll see one of those in just a few minutes here. So we want to evaluate. Number 2 step is chlorhexidine rinse, 2 times for 1 minute each. And we want to make sure that we reduce as much of the bacteria floor as we can. And number 3 is anesthesia. And I've played around with this quite a bit. I've played around with infiltrations and just numbing the whole arches up. That takes time. And patients don't really like to get a shot. What I found works fantastic is this PFP thick 30 grams from Steve's Pharmacy in California. And most of the time, if we're going to penetrate just about 2 millimeters into the bone, this is enough. And it's 10% lidocaine, 10% prilocaine, and 4% tetracaine, and 2% phenylephrine. I haven't seen any problems with this. I leave it on for about 5 minutes, and then we take it off. And I let the patient sit for another 5 minutes. Now, if you leave it on too long, you're going to get sloughing of the tissues, so it's a fine balance. Again, like this is showing infiltrations. If we need it, we can do that, but we're really not perforating into areas that require a shot. So, treatment considerations. Most patients require 1 to 2 treatments, and complex cases may require 3. 2 to 3 manual osteoperforations are recommended mesial and distal of the tooth, and I'm actually finding that less and less, maybe 2 per side, and if I'm doing full arches, I'm doing 1 to 2 in between each tooth, between the upper 5 to 5, lower 5 to 5. Now, for acceleration, we perforate around rate-limiting movements. If we know a tooth is going to have a problem moving, then we can come in and perforate. The depth selection, we'll talk about this in a few minutes, but usually the anterior is 3 millimeter, posterior anywhere from 5 to 7, and the palate 7 millimeters. We need to make sure we get through that thick tissue. Osteoclastic effect peaks in 24 hours and remains elevated for 10 to 12 weeks. So if that's the case, we may be doing this 2 to 3 different times during treatment if we want to be done in 12 months. Okay. So here's the technique, and this is our disposable unit right here. We can set the depth, rotate clockwise while applying the gentle pressure, check the engagement with the light, tug back, and obviously that LED depth, which is really nice, will light up when you're at the right depth. And we just back it out normal. Where are we going to perforate? And we can do buccal, we can do lingual, we can do up on the palate where the canine is. It really is... it's an open field for whatever you feel like you need for desired movement in patient's oral anatomy. And this picture up here on the upper left is just showing a patient for me that had stubborn space closure, and I did some perforation for that. The question you might be asking yourself is, how deep do I perforate? And you know, where the idea of just designing, and this is an article by Baumgartel. And basically in the anterior, we're going to go 3 millimeters, the posterior 5, and typically I don't go any more than just 5 millimeters in the posterior. Those are recommended depths. How many? You're going to see here in a few minutes. I've experimented with this. I've done a lot. I've done a little. And basically, I don't think that we need this where we have 3 in between, unless we have a really stubborn area that we want to make sure that we increase the change of the bone here. We'll do 3 or 4, and sometimes we can do different patterns. But the technique is pretty important. We remove the tip. Now this is our disposable tip, and We'll release it and click it into our driver here. Hold this driver at a 90-degree angle to the gingiva, making sure the tissue is tight. I try to stay away from the unattached gingiva. We'll rotate clockwise while applying that pressure. And again, this is great. The electric driver is fantastic. So it's up to you how you want to do this. This is showing some sites immediately afterwards. This is, you can see where on this perforation site, you can see where the plastic sheath has gone into the tissue a little bit. And with the electric driver and the new tips, you don't get any of this here. This is showing perforating for this one area here with aligners. And so we perforate with whatever driver you'd like. So post-treatment instructions, many people say, well, what do you do for our patients afterwards? And basically, we tell them that they're going to be tender around those sites for 24 to 48 hours, similar to that of an orthodontic adjustment. I tell patients they're going to feel their teeth being more sensitive from their adjustment than from this perforation. We are really clear to them about not taking the NSAIDs because we know that's an anti-inflammatory. This is all built around the inflammatory response that brings the cytokines in and starts that cascade of rapid movement. So we do not want any Advils, only Tylenol, and really one extra strength Tylenol is plenty. Perforation may be repeated in 10 to 12 weeks as needed, and post-treatment instructions are similar for a local or topical anesthetic. So that is basically it. Very, very straightforward and simple. This is manual osteoperforation with aligners. And basically what this does for us, now I know Invisalign has gone to 7 days changing out their aligners, but what this does for us, it enables 3 to 5 day intervals and changes with our aligners. We perforate the appropriate area and provide the patient with the aligners. See the chart below. And you can see that you know, if we need to go to 9-day intervals, we can, but now that we've gone with this osteoperforation, we can increase that rate, give the patients 10 aligners, see them back in 4 to 6 weeks. Now, returning patients, you know, the aligners are fitting fantastic. When we perforate, the tooth movements are amazing. And we'll perforate mesial distal for those non-tracking teeth, you know, those stubborn teeth that just aren't moving. Well, you want to turbocharge that. You just do some perforations. So with brackets now, this is where I've really paid attention, is manual osteoperforation with brackets. And this is really proactive acceleration, maintaining that same biomechanics, the current bracket system that you're using. For me, I use passive self-ligation, so I'm still going to use the same type of biomechanics that I use. I'm not changing that up. What I am changing is I am shortening the treatment times or the treatment appointments. It's basically 50% of what my normal intervals is. So if I would start a case, put an 014 copper NiTi in, and I would see them back in 10 weeks, now I'm going to see them back in 4 to 6 weeks. And I'm going to do my normal biomechanics. We'll level the line. Well, really this fast tracks our movements for giving us more opportunity for finishing. You'll see here in a few minutes with one of the cases I show. We'll perforate mesial and distal to the sites where mechanics call for the greatest movement, or if we're having stubborn areas. Many cases are delayed by little difficult movements. This perforation will make that move very quickly. We'll accelerate mesial and distal to those areas and fast track either alignments or bracket movements. And notice now, one thing you need to realize that for sliding mechanics, in some cases, if we're fast tracking this, movements can cause rotations and forces, and if we're not evenly distributed. So plan your mechanics. If this happens, you may need to place buttons on the lingual as you're sliding teeth forward to help prevent rotations or other, you know, things that you just don't want to occur. Perforations can be done every 10 to 12 weeks as desired with our brackets as well. So now there are times where we have reactive acceleration, and at finishing or detailing, let's say like you're having stubborn space to close up and you're about done, you can go in and you know, do a little bit of perforations in an area that might need some precise finishing. and that will just get you home. These are other areas of places where I've used manual osteoperforation. Crowded cases, space closure has been huge for me. Molar uprighting is big. Mesialization, protraction is I use it all the time. Distalization, pre-prosthetic, rotation, impaction, extrusion, you name it, you can use it. It facilitates the successful completion of a variety of other malocclusions, including not limited to intrusion, pre-implant therapy, congenitally missing teeth, midline discrepancy, open bite, deep bite, you name it, you can use it, and you will see acceleration in your tooth movement. So I want to talk briefly about high-frequency vibration, basically using this with my clear aligners, and I'm seeing the clear aligners turbocharged, teeth sliding into place. 5 minutes a day is all that we need to do, and we'll seat those aligners and seat those teeth into the aligners. Makes very predictable movements with our clear aligners. We have a mouthpiece and an oscillator. Now there is a USB flash drive preloaded with some summary software and a wall adapter for charging cable. The delivery, will remove the device from the packing, clean the mouthpiece, rinse, very straightforward. We charge the device fully prior to giving it to the patient for the full use. Clinicians will assign the device to a specific patient ID, and per respective our practice and prior to the first patient appointment. Once it's assigned, we'll be ready for use. Now, the cool thing about this is interactive, and we can see what's going on and how the patients are wearing this thing. We'll connect the mouthpiece to the vibration device, confirm that it feels secure and stable, press firm until that snaps into place, and then we'll ramp up to full vibration. The device will function for 5 minutes per use and will automatically shut off after the duration. An LED notification light blinks green and indicates the cycle is complete. Very simple, very easy to clean afterwards. Now, you can see we've got this nice little blue light, continuously blinking light during your cycling. 3 blinks means we've been completed, and green continuous is the device is fully charged. Red, we've got, with anything, if we interrupt treatment or we have troubles, we'll get a red blinking 3, and you can see there's different device blinking for different problems. So we'll design and add this device to the patient, and we'll be able to access the usage data at each visit. And if you're into this kind of stuff and looking, well, we can have some great statistics and be able to really see what's going on. So I'd like to get into some cases and show you. I'd like to thank Tom Shipley for letting me use some of his cases that he's done with Invisalign here. This is very cool because it shows you very quickly what happens here. This is a treatment plan with aligners and perforation, and 3 months using 1 osteoperforation, you can see changes that happen. The beautiful results. That's the kind of thing that we see on a daily basis here. Here is a lower incisor extraction case. If you've ever, had a desire to do this and you wanted it to be predictable, well, here it is right here with osteoperforations, 5 months with 1 perforation application, and look at the result. Great work, Tom. Very nice. I want to show a couple of my cases here. Now this is with brackets, opening implant space for missing teeth. This is a patient that's missing his upper right 4 and lower right 6. Very difficult case. This is Hubie, and he's missing teeth. He wants implants, and these cases are so difficult. He's edge to edge. He's class 3. The midline shifted off to the left side of his left. Bilateral posterior crossbite. Wow. I mean, he already has root resorption. He has the gamut here. But he wants treatment, and for me, I say to myself, what are we going to do here? We're missing teeth. To get this to line up and to give him more anterior overjet, we need to open up space for this upper right 4. Obviously, we've got our crossbite. We're going to correct that crossbite and get a good occlusion for this gentleman, as well as opening the spaces. So you can see we're going to go in, we're going to open it up, we're going to do this non-extraction, we're going to line the midlines up, but we're going to use manual osteoperforations to help us for these sites. Okay, you can see here he is. There's his before and after. We've lined his midlines up. We've corrected his occlusion. He has good overbite, overjet. Posterior bilateral crossbite's gone. You can see he's in great shape here. This is just showing what we did. We performed micro osteoperforations at 8 months of treatment, and this was performed on the distal of the upper right 3, distal of the upper right 5. 3 perforations were initiated and the space 3 millimeters apart vertically. Within 3 months, we did 3 millimeters of space had opened, 6 millimeters, or at 6 months, and then the space was fully open and the space was ready for implants after that time. So only 1 perforation procedure was done in this case. You can see this was the initial at 3 months, and 6 months you can see how much space was opened. I could not have accomplished this without perforations, and you can see when you get here to see what's happened, a huge amount of bone. Look at the palatal vault change, and I believe that a lot of this was accomplished because of the perforations. Here he is after implants, and you can see we've got implant space in there, maintaining a good crossbite fixed, and 20 months of treatment time. We couldn't do that before. Here's another case that we've been doing, and we have these cases where we will open up implant space from previously extracted bicuspids. These are tough cases because patients want to have their teeth back, they want to enhance their facial features, and in this case, Julie, we went and opened up the space, and once we got the space open, we had asymmetric closure where the left side closed faster than the right side. So I proposed, after we opened the spaces, to use TADs to close those spaces, anchors to bring the molars forward. And at about 14 months of treatment, we were having a real tough time on this right side. So we went in, did micro osteoperforations here, and space took 4 months to close after that. I don't know if I ever would have got it closed had I not done the osteoperforations here. You can see this is where we were struggling. And this is just one way that we've used to close spaces, and I've tried many others. But afterwards, the spaces are closed. We widened her upper jaw and had a beautiful result. Stubborn space closure during treatment with brackets and wires. I talked about this earlier, where a patient will come in, we're at the end of treatment. What do we do if we have stubborn space? This will help us get done quicker. This fellow had a really easy treatment plan, nothing big, but we were having trouble due to tongue and other problems. So we used the perforations to help us close the spaces. And after 10 weeks, we did it again, and we closed it 4 weeks later. But you can see here, in this case, we've got our perforations with some power chain closing up the space. Here he is after a second time. I just did a little bit in this one area to finish up the spaces. He had a nice result, and he's finished. This is the day he actually got the braces off. As you can see, the tissues are still healing, and there he is. So other cases that I've tried osteoperforations on, some of these cases show that they're difficult to do. I've tried ankylosis. Upper left one was ankylosed. What I did was I put brackets on this fellow, and he lost his front tooth in a wrestling match in high school. Tooth was out for 1 hour. Oral surgeon said they wanted to extract the tooth, but it'll leave a horrible vertical defect. My idea was, let's go and put brackets on there. Let's osteoperforate and see if we can't get this tooth to move. Now, in this case, I did it 2 different times, and it didn't work so well. We didn't get what we wanted to, but we tried. Sometimes we have cases, and I'll show 2 cases. This is an adult with collapsed arches, and on this case, I was having a very difficult time uprighting canines that were very severely dumped in, and so the whole posterior segment is dumped in, so I used osteoperforations on both posterior segments, right and left, to get uprighted, and you can see we've just gone in, and then we've 6 weeks later, you can see that she's starting to upright in the posterior, and there's a difference between the before and after, and showing a much broader posterior segment with osteoperforations. Other tough tooth movements that I use osteoperforations with, and we've got a patient here that has a vertical defect on the upper right tooth. The plan was to try to extrude this upper right tooth, bring the tissues down with it, and after 2 months progress, we didn't have much progress with it, so we decided to substitute the cuspid into the lateral spot. So we pulled the upper right tooth and brought the cuspid forward. Now, we had to use osteoperforations to actually help us with this big cuspid, and you'll see here in a few minutes we wouldn't have been able to accomplish this movement without that. So you can see that we're in treatment here, and the upper tooth has been extracted. We're using good mechanics here to slide the cuspid forward, but we don't want to just tip the cuspid into that spot. We want to bodily move that cuspid forward. So we're using micro osteoperforations or manual osteoperforations to accomplish this. And we're going to do a cuspid substitution case and then slide the posterior segment forward. Again, this is once we have bodily movement of the cuspid forward, it's touching. And then they're actually, in this case, the patient was going to get an implant where the cuspid was. Here's the during treatment and the after with the implant placed. So canine slid forward and an implant for where the canine was, and this gentleman has a great smile. There are other areas that we can use osteoperforations to help us. This patient was a really interesting patient that came in. Fascinating, to be honest with you. This is Jamie, and she came to me looking for a wider smile and to reduce the amount of gum show that she has. Interesting, she says that she hates her gummy smile, and she is personal friends with another orthodontist in town, and I'm asking her, I'm like, why are you here? Why wouldn't you go to the other orthodontist? And her comment is that she was just getting a second opinion. And she said, I may be moving in 7 months. I want fast treatment. In fact, I want Invisalign. And I just let her know that Invisalign wasn't going to help her. If you look closely at her 3D here, you can see that she has some severe exostosis or buccal tori, upper and lower. This type of a case is very difficult. If you look here, many people would be intimidated by these huge buccal shelves, buccal exostosis, and all of her teeth are dumped in, and I call them collapsed, and she wants treatment, but she wants it done fast. And you know, this type of a case is a very difficult case to get arch width and to be done in a quick, timely manner. So I talked to her about osteoperforations and told her that we can correct and get the arch width. Now, I've heard of some articles and doctors saying they can reduce the exostosis by using the perforations into this hard bone. It's not recommended. I don't recommend it. I tried a little bit of it. It's very difficult to get through, and I wouldn't do it again. But in this case, we're going to widen out her arches, upright, eliminate the crowding, and we're going to use manual osteoperforations to help us so that we can get the teeth to actually move. And remember in the beginning, when I talked about the actual movements, and what I want is bodily movements. I want bodily movements with the posterior arch to widen out, and I don't want to just tip or flare teeth, and I don't want to take the teeth, the roots through the bone. So my idea was to use these perforations to help get bodily movement in a quicker manner, but more efficient and in a great way. You can see that her incisors are retroclined. We want to bring them out. You notice that I do scans and look at the palatal vaults. She wants to reduce the gummy smile. We're going to widen the smile. We're going to accelerate treatment. Now, she wanted Invisalign. I told her I wouldn't be able to accomplish it and get what her goals were and what mine were. But I told her I wanted to treat her in 10 to 12 months, and we would do these perforations, and we would do it several times. So I'm going to show you, we're using passive self-ligation brackets. We're going to use the perforations 2 to 3 times during treatment. Now I apologize about some of the pictures, and we've had conversations with my team members to help me as this was immediately after placing brackets and doing our perforations, and I've asked the assistants to clean these pictures, so I apologize. But you can see where we've perforated, and these are just a couple of perforations in between. And you notice I really didn't do any on the lower. We're just going to be uprighting the lower, but we wanted to widen the upper, so it was mostly just the upper. These are just the different types of torque brackets we use. We won't go into that much. So this is showing that we did perforations at the initial bonding appointment, and again at 3 months into treatment. At 4 months, the patient is in finishing wires, so you got to imagine. So we went from 0 to 100 miles an hour in 4 months. And patients will stay in the finishing wires for probably longer than 3 months. We'll probably be in 6 months. So initial, at 3 months, we re-perforated, and 4 months we're in our final wires, and we're working on arch width. You can see what's happened here. She's at 4 months into treatment. We're getting some arch width, but we're nowhere near where we want to be, so we keep working. You can see up close the perforations. We went from the posterior, in fact we did some between the 6 and the 7, all the way to the other 6 and 7. No reason to do the lower because we're mostly just uprighting. There wasn't any difficult movements there, but it was that upper arch that was the problem for me. And I know that with those exostosis, I was hoping to get as much help as possible. So my mechanics started off with 014 copper NiTi for just 3 weeks, and 018 for 4 weeks, and then we placed 1425 at 7 weeks and 1825 at 10 weeks. And we took more pictures. You can see here we are at 7 weeks into treatment. Things are starting to move. The posterior is starting to widen and broaden. You can see things are changing. Very straightforward. Here she is at 3 months of treatment. Again, nowhere where we want to be, but things are changing quickly. These types of cases require good bracket placement, good mechanics. This is just showing we're still working on the anterior with our torque, getting the teeth into the right position. At 3 months, we used another perforations, and just to help us keep broadening and widening the smile. Here she is at 4.5 months in treatment time, and no repositions, just placed final wires and kept working. As you can see, the bone looks healthy. We're in great shape here. 5.5 months into treatment, we put our stainless steel wires and did some torquing and some finishing, and we're just doing adjusting, creating this beautiful smile, working on the arch width. And you can see we're getting closer to our goals. At 7 months in treatment, we propelled the upper arch again, upper 6 to 6. 8 months in treatment, we're still working on our smile and our width. 8.5 months, we changed a bracket. 9 months, we're repositioning a few brackets. Of course, all the way down to 11 months, we're just about done with treatment, and 12.5 months, 13 months, we're done. So Jamie, at her finals, you can see how broad and wide her smile is. We're going to do a little gingivectomy on her to help her with her asymmetric gingival show here. She smiles so much you can see the exostosis, but we're going to go in and do a little bit of contouring. Look at her beautiful smile. The teeth are upright. She is happy. Look at her profile. Profile looks amazing. Here's her finals before gingivectomy. And we're going to go in and just enhance slightly on this side to help with leveling out her asymmetric gingival show over there. Again, we're never going to overcome these exostosis, but we wanted to create an upright posterior segments, wide, beautiful smile for her. And you can see this is 3 weeks later. She's healed beautifully. 1 month after healing. Look at how beautiful her smile is. The contours are right. The posterior segment looks right. Here's 12.5 months into treatment. After all of the healing of the tissues. And I got to tell you, she has a beautiful smile, good posterior occlusion. She's going to get a few crowns replaced on the lower, and she's in great shape. This is what can happen, and I was trying to explain that with the perforations, I believe that's what helped me get the arch width to create a beautiful smile like this and to overcome her gummy posterior segments. So the question that I leave you with tonight is, what do we do? How do we handle these cases and handle these patients that get done faster? Well, I'm obviously, I told you before, I'm an investor in OrthoFi. I'm a big believer in helping patients finance their cases over even we're finishing shorter, and what do they do with payments? And we're going to use OrthoFi to help us. And OrthoFi basically is going to give us better financing options for these patients and allow them to pay over time, even though we're done faster. And I'd encourage you to look into this if it's something that you're interested in. We customize our plans for our patients, and OrthoFi is a fantastic company that now has well over 225 users that are using this software and this customized treatment planning for the patients and as far as their payments. And I would highly recommend you looking into it. We have to do something to help these patients because many of them want to accelerate their treatment, but they can't pay in 12 months or less time. So 12 months, that's really what we're trying to do. And with the heavy fees associated with this, patients can just design what they want. And you can see they're wanting to design their treatment plan as far as payments are concerned. How do you begin using Propel? Call your Propel rep. Ask them to come and do a lunch and learn with you. Identify cases at your practice where you could use perforations to benefit or enhance the case. Start accelerating your practice today. If you want, you can go in the May-June orthodontic practice. I wrote an article on self-ligation with accelerated orthodontics and the new opportunities. Happy to share that with you. And just want to say thank you for being here. And I'd like to take a few minutes now. If you have a couple of questions, be happy to answer those. Great. I'll wait here. This is a question. Let's see if I can. This is from Sunny. How have you liked using OrthoPulse? Any concerns with patients asking for possible cancer with using it? No, I liked OrthoPulse. The patient that used it said that it was soothing to the teeth, and she really liked it. This is from Jorge Vargas. Jorge, thank you for sharing this with us. Thank you. And this is a question from Amy. What do you charge your patients for perforation? And do I add it to the cost? I got to tell you, I build it into my fee. I charge a healthy fee. My idea is this. If you give more in value than you receive in money, then you're going to have a very healthy practice. And I don't charge patients for accelerated treatment. It's built in, and I want to just provide that for them. So there's no additional fee. And, perforations aren't that expensive, and it's pretty simple. So this is from Fabio. Once again, it's a great pleasure to be able to watch you lecture. Could you talk about Damon protocols, using this with Damon protocols? We talked about that earlier. You're welcome to go back and look at it, but basically what I do with my my practice with Damon protocols is I use the same protocols, but 50% less time in between those adjustments. So I use the question is, do you use double arches in the same slot? For example, 2 copper nine ties. I don't. I keep everything the same and just less time between appointments. So the question is about charging for the V Pro 5. I don't charge. I do increase my fee slightly, but I don't charge extra for it, and they don't ever see the cost on that. This is from William. Have you ever used dental monitoring software to measure the rates of movement? I have not. I think it would be fascinating if there was some software out there that would really be able to help us monitor, how fast this is really happening. With that last case that you saw, that case should have been an 18-month case to get the result that I did get. So I'm showing at least a 6-month change in treatment time. And to be honest with you, William, I don't know if a dental monitoring software even exists. What I would recommend to all of you that are out there that are wanting to get started in this and see changes, you take photos at your appointments before and after and during, and look at what happens, measure the cases, pay attention. If you do that, you're going to be able to see what's really going on. Well, it looks like I have time for one more question. Otherwise, we're going to be done. Let's look real quick here. William put up this www.dental-monitoring.com. Hey, something to look at. It might be kind of cool. I have never heard of it, but definitely appreciate the suggestion there. So with that, thank you for your time tonight. You've been wonderful. Appreciate it. If you ever get to Arizona, please look me up. Look forward to seeing you at meetings, and thank you very much.